Welcome back. Our next speakers are Dr. Melissa Young and Dr. Indira Guleria. Both are tissue typing directors, respectively, at the Brigham and Beth Israel. They will be talking about immunological assessment pre and post-transplant. I'm looking forward to their talk. I continue to learn more and more every year from them. Melissa?
Great, thanks. It's a pleasure to be here for another year again. So the first part of this talk will focus more on sort of the theoretical aspects of the HLA typing that we do to assess histocompatibility. And then Dr. Guleria will walk you through some examples of cases to highlight the issues. All right. So here are my disclosures. So I'm sure Dr. Azi went through this, but just to recap, we reject a transplanted organ because essentially our immune system recognizes it as being foreign. And the molecule that is most recognized as being foreign happens to be the HLA molecule. And the reason for that is that the HLA molecule is extremely polymorphic across the entire human population. And we've now identified more than 18,000 distinct HLA proteins. Of course, we also have to consider ABO blood group antigens, and there are some other proteins that may show some polymorphism, but those are much more highly conserved. And so when one's immune system recognizes a foreign entity in the context of alloimmunity, that usually leads to two main arms of rejection. One is the cellular rejection, and the other is the antibody-mediated rejection. For the most part, all HLA testing that is currently clinically performed in laboratories really focus on assessing your risk of antibody-mediated rejection. Now, of course, given if somebody has an antibody that has developed against their donor, then that must by requisite mean that they have some sort of T-cell memory response, because one does need T-cell help in order for B cells to make antibody. So, but there are no assays that we currently use that directly assesses T-cell reactivity. So when you think about when in the process of evaluating your patients, you're ordering our testing, let's start first here. So you have your candidate, they're coming up for transplant evaluation. And the first thing that the pre-transplant team will do is order HLA typing of the recipient. And they will also order a screen to see whether your patient has developed any HLA antibodies. When a potential donor comes up, whether it be living or deceased, then the laboratory performs HLA typing on the donor. And in comparing these two HLA typings, donor and recipient, one can then assess the degree of HLA matching or mismatching that's there. Using the donor HLA typing and comparing it to the prior results of the HLA antibody screen, one can then try to assess whether the patient has previously formed or pre-formed donor-specific antibody against that particular donor. And that's what's known as donor-specific antibody assessments, or you may also heard the term a virtual cross-match. Following that, sometimes one might decide to do physical cross-match. That's when you're actually taking patient sera and directly incubating it with donor cells to see whether there's reactivity there or not. And the physical cross-match testing that we'll be talking about come in two flavors. So there's the CDC cross-match and the flow cross-match. Using all of this information in totality, then transplant clinicians and the HLA laboratory are able to sort of recommend whether to decide to move forward with transplant. And then also, if they decide to move forward with transplant, what sort of immunosuppressive regimen may be recommended. And that goes for induction therapy as well as maintenance immunosuppression. And if one is crossing a preformed DSA, one might also consider whether desensitization or peri-transplant approaches to reducing alloantibody are also necessary. Post-transplant, of course, this same HLA antibody screen that's used up here is going to be used to monitor whether a patient forms new or de novo donor-specific antibody following the transplant, or to also assess levels of preformed DSA and whether they're still persistent or not. We're not going to, suffice it to say, given that the test is the same, we're not really going to focus too much on sort of this DSA monitoring process. If the candidate doesn't have any potential donors, then this information that we got from the HLA lab for the candidate evaluation also helps us determine what's known as the CPRA, or the Calculated Panel of Reactivity. And it helps us to determine which antigens we may not want to cross. And so that's termed an unacceptable antigen. And this then tells us what the likelihood of a timely transplant for these patients are. And given that, one then would decide whether the patient just gets put on the deceased donor list, whether one needs to consider desensitization, or if the patient has a potential living donor that they're HLA incompatible with, whether a paired exchange would be possible. So let's illustrate this by, considering two cases. So there's patient A, a 35-year-old with end-stage kidney disease who's been on dialysis for 5 years. She's waiting a deceased donor kidney transplant, and her CPRA is not that high, it's 32%. Contrast that with patient B, who's around the same age, has been on dialysis for about 6 years, but their CPRA is 98.2%. Okay. So in addition to knowing that HLA antibody profile, one, again, needs to consider whether all those antibodies would be considered unacceptable. And thereby, if you have those antibodies, you don't want the donor to have those antigens. And so, you can your program will set various criteria for the thresholds of calling antibody. And this, of course, may very well be dependent from or different program to program, but also could be individualized as well. For example, in a pediatric patient, you may not want to take any risk at all, and so you may lower that threshold to make sure that you're capturing any possible alloantibody that's there so that you're not crossing any preformed DSA. On the other hand, if we're talking about thoracic organ transplants that are life-saving, they have more of a tolerance to cross preformed DSA if the need for an urgent transplant is there. In addition to this virtual cross-match assessment, one might consider doing physical cross-matches as well to help you further assess that. And so in the kidney world, a TCDC positivity is pretty much an absolute contraindication to moving forward with transplant. And the reason for that is in the seminal paper by Paul Terasaki in the New England Journal, now more than 50 years ago, he showed that if you have a positive T-cell CDC, that means that your alloantibody profile is so reactive against that particular donor that if you put in a kidney, 80% of them are going to get hyperacute rejection and lose their allograft right on the operating table. So that's why that's an absolute contraindication, and that's why hyperacute rejection barely ever happens now because of the testing that we do in our lab. The flow cross match, though, even if it's positive, that's only going to be a relative contraindication. And again, it's going to be dependent on the strength of the cross-match positivity, the presence of the DSA and the strength of the DSA on the antibody screen. It may depend on donor characteristics. So if this is a marginal kidney and all of a sudden you do see already some low-level DSA, then that might not be acceptable as a combination of a risk for that graft. However, if this is a very young, otherwise healthy donor, and this is a very highly sensitized patient who has not been getting a lot of offers, then you may be a little bit more flexible about whether or not you cross a low-level antibody. And all that comes down to trying to make an assessment of whether you think if you pass on the offer at hand, what that likelihood of another timely HLA-compatible kidney would be. And that would be contrasted, of course, with the risks of remaining on dialysis. So one really needs to think about specifically for each patient what immunological risks would be acceptable for your particular patient, and also at the time of organ offers, what that might also change depending on the donor characteristics. So let's back up and just kind of go over the sort of some of the basics of HLA. So HLA is the alleles are grouped into class 1 HLA and class 2 HLA. Class 1 HLA encompasses the A, B, and the C loci, and these antigens are expressed on all nucleated cells in the body, so everything except for PRBCs. Red blood cells. And the class 2 HLA antigens are comprised of the loci HLA DP, DQ, and DR. And predominantly, they're ubiquitously expressed on antigen-presenting cells like dendritic cells, monocytes, B cells. But the reason they become important in solid organ transplant is that they can become upregulated on endothelial and epithelial cells under inflammatory conditions. And of course, as we all know, IRI is the perfect inflammatory milieu. And so if there is antibody against class 2 molecules, we need to know that as well, because we do know that that is going to cause ABMR. It's important to remember that expression is co-dominant. So you're gonna have one set of HLA molecules from mom and one set of HLA molecules from dad, and so you may express up to 12 different HLA molecules on your cell surfaces. The other thing to note too is that expression levels can modulate immune responses, i.e., if you have less target of the antigen on the organ, then even if you have high levels of alloantibody, then that's not necessarily going to lead to end organ issues. And so this is one reason that folks may not be as familiar with HLA-C and HLA-DP, because historically these have been considered less clinically relevant on that basis. And that's because the cell surface expression levels are much less than the other loci. There are case reports and case series of these antibodies causing ABMR, but there are also numerous cases where we've transplanted across HLA-C and HLA-DP antibodies without any issue. Okay, so as I mentioned, HLA is extremely polymorphic, right? And if you look at the number of HLA alleles that we've characterized now, it's more than 30,000 distinct HLA alleles, leading to over 18,000 distinct HLA proteins that are expressed amongst the total human population. Luckily, however, in the context of solid organ transplant, we try to sort of like group these HLA proteins into sort of groups of what we consider to be serological antigen equivalents, meaning that we think that they should react similarly given an alloantibody directed against one. So to understand that a little bit better, let's take a look at the molecule itself. So this is a class 1 HLA, for example. And the molecule is a heterodimer, but the heterodimer is comprised of a highly polymorphic alpha chain, which is here, and then a very well conserved beta-2 microglobulin. And it turns out that the part of the HLA molecule that's immunogenic and antigenic is known as the antigen region. Okay, so this is the region that can elicit a response. And so if an antibody develops against areas of this region, then the antibodies that develop typically are going to be against an epitope in this region. Amongst an antigenic region, there can be multiple epitopes, though. So you can have a polyclonal response to one particular molecule. For class 2, it's a little bit more complicated because actually the heterodimer is made up of the alpha, and the antigenic region of that heterodimer is made up of both the alpha chain and the beta chain. And in some cases, the alpha chain is also very highly polymorphic, such as in DQ. Okay, so one has to consider that there may be antibodies that are directed against the DQ beta chain, right, which is the classical thinking. But up to 25% of DQ antibody actually reacts against the alpha chain as well. So if you have polymorphisms in the alpha chain, you have to consider whether or not that would lead to reactivity if you have a particular DQ alpha antibody. There are also other antibodies that are now newly characterized as requiring both the specific alpha and beta heterodimer pairings. So how do we know, what a patient or what the donor's HLA typing is, which HLA proteins that they're actually expressing. So these days, the testing is done by DNA-based molecular methods. Okay, there are two main categories of it. The first is what we call low or intermediate resolution typing. And the low or intermediate resolution typing is really only going to resolve protein differences at the antigenic or serological level. So what I mean by that is that if the antigenic region is similar between two different alleles or two different proteins, then they're going to be pretty much categorized the same way via low intermediate resolution typing. And you may not be able to distinguish between those two alleles if the polymorphism is outside of the antigenic region. So really, the goal is of this assay is to really just focus on those core exons and identifying the antigenic, highly polymorphic antigenic regions. The second grouping are the high-resolution typing methodologies. And these days, it's mostly via next-generation sequencing, where we can basically sequence the entire HLA gene, including some of the introns. Okay. Now, you might ask, well, why doesn't everybody just sequence the entire HLA gene all the time? Well, for most cases of recipients and living donor, that's what we typically do in the United States. But we don't do it necessarily for deceased donor typing because most next-gen sequencing methodologies have a turnaround time of a few days, which is way too long to sort of for deceased donor allocation. So the majority of deceased donor typing is still being done by these intermediate resolution methodologies, although there are some new technologies coming up. If you're outside of the United States, then sometimes intermediate resolution typing is still relied upon because of cost. Okay, so just to make sure that everybody understands this concept of serological antigen equivalence, I like to give people an analogy of it. So let's focus first here on that left-hand panel, and let's pretend you're the immune system, and you want to ask yourself, like, what does the immune system see? And so if you're driving through your neighborhood and you look at these three houses and they're all a red exterior, you can't tell them apart, okay? So they all look the same to you. And this represents what you can see, which is the antigenic region of the molecule. Inside the house, the layout or the furniture may be completely different, but that's not accessible for the immune system to see. So what that means is the polymorphism is elsewhere outside the antigenic region. So the way that we tell you that is that molecularly we give you they are named different alleles. So for example here, AO201, AO203, and AO206. If we think that they all react the same serologically, then we group them into the same serological antigen equivalent, in this case, the A2. Having said that, there are now some further discoveries that sometimes what happens is even though we think that these polymorphisms may be outside the antigenic region, they can affect or show differential antibody reactivity to the others in that same group. And in which case, these days, sometimes they may be known as allele-specific antibodies, but actually, they actually should just be reclassified as a new serological antigen entity. Okay. In the middle scenario, you can see that if you drive through, each of the three houses are distinct to you. And so this represents three serologically different antigens. In this third scenario on the right-hand side is something known as a shared epitope. Okay, when you drive through, you can recognize these three houses as being different, but you also realize that these two houses over here have a green roof, meaning that if they actually have an epitope that's shared or common amongst them, then an antibody that reacts against that epitope is actually going to react against multiple different antigens. Okay, so it's not simply that each serological antigen equivalent has only just one epitope and that epitope is unique. No, one can have shared epitopes and cross-reactivity. Okay, so when a donor becomes available and you want to decide whether this is a well-matched kidney or not, let's think about how some of the nomenclature or terminology that's used. So we term something an HLA mismatch when you have an HLA antigen that appears foreign to the recipient. So it's unidirectional. So the HLA antigen is found on the cells of the donor allograft, but not in the recipient. Okay, that's the case in solid organ transplant. Of course, in bone marrow transplant, we have to consider the bidirectional case because the opposite direction dictates graft versus host. Okay, but in solid organ, you're really thinking about what the recipient's immune system can see on the allograft that's foreign. The other term that I think is a little bit of a misnomer now and outdated, and I personally think we should get rid of, is this concept of a zero mismatch. Okay, historically, a zero mismatch has been characterized as being sharing the same HLA-A, B, and DR antigens. Okay, but of course, as you just heard, we all have three other loci as well, right? And so even if you're a zero mismatch or a 6 antigen match with your donor, that doesn't mean that there isn't any mismatches at the C locus, the DQ locus, or the DP locus. Okay, and that becomes important because if you were truly haploidentical and you had a 12 out of 12 complete matching, then those are the cases like, for example, the very first transplant that was done here at the Brigham back in 1952, where you didn't even need immunosuppression, not even prednisone, because the transplant was between a patient's identical twin gave him the kidney, right? But that's very, very different from saying it's a zero mismatch, meaning they're not mismatched at just A, B, and DR, because they are likely to have mismatches at the other loci. And so I think it's a misnomer, because then you really don't have that that consideration. So why not wait for a 12 out of 12 match, right? And the reason is because it's a needle in a haystack when we're thinking about that. And if one were to wait for a 12 out of 12 match, then people would be waiting a heck of a long time, because kidneys themselves are scarce. And those with rare antigens and those of ethnic minorities would be waiting even longer. Okay, let's switch gears and quickly talk about how do we detect preformed HLA antibodies. So the goal of this is really to determine whether patients have preformed HLA antibody against their donor. And we would want to define its specificity, and we want to probably also determine their relative amount or strength. And the way we can do so is through three different methodologies. We can use the physical cross matches, where we are actually assessing patients' sera with the donor cells, and or the flow cross match, which is also set up the similar way. Or we can use a bead-based assay where donor cells are not required, so you don't necessarily need to know who your donor is ahead of time. So the CDC cross-match assay, this is how it works. So you take your donor T or B cell fractions, you add your patient's sera to it, and then you add your detection reagents, which include an augmentation anti-human globulin and complement. And if there was alloantibody that bound to the cell of the donor T cell or B cell, then your readout would be cell lysis. And that would indicate that there is some form of IgM or IgG donor-specific antibody. Now, that doesn't necessarily mean that that donor-specific antibody is against an HLA molecule. That could be reactivity against a donor antigen that's non-HLA. And I think Dr. Galeria will give us an example of some of this. All we know is that this patient's sera shows some reactivity to the donor cells. The important thing to point out in the CDC crossmatch is that it can assay both IgG DSA as well as IgM. And so really it's only pretty much the only assay that we use to detect IgM HLA DSA. And so if a patient has had a recent sensitizing event where a seroconversion has not yet happened, you might get this assay, if it's very, very strong, to be, or if the antibody is very, very strong, you might get positivity on this assay, but negativity on the others. And that's because in the flow cross-match assay, the detection reagents that you're using is a fluorochrome conjugated secondary antibody, but this secondary antibody is only going to be able to detect IgG. Okay? And so the setup of this assay is very, very similar, but the readout is then by flow cytometric methods. And you compare the fluorescent intensity of your patient that results from your patient sera to a control well of normal human sera for background reactivity. And so labs will report that out either as a mean channel shift or as differences in direct fluorescent units. And so the threshold for positivity is then set by the lab. And obviously, the lower the threshold, the more sensitive, but the higher the false positive rate. And then the higher the threshold, the less sensitive, with a higher false negative rate. What about the most sensitive assay, the single antigen bead-based assays? Okay, so in this case, as I mentioned, instead of using donor cells, you're actually using beads. And it's a multiplexed assay that contains multiple different colored beads. And so you can tell each of the types of beads apart because they're different colorimetrically. And so to each of these beads are coupled a different HLA molecule. And so if you have alloantibody in the patient's serum, when you add it on, it'll just bind to the particular bead. Again, we use a secondary fluorochrome conjugated antibody that only detects IgG. And then the readout is basically something like this that's by flow cytometry, or otherwise known as Luminex, and you get a mean fluorescent intensity of what this looks like. Okay? And again, the labs will set the cutoffs to be more stringent or less stringent in calling antibodies. Okay, so to quickly go through, the other concept I mentioned was something known as the CPRA. And so the CPRA takes the results of that bead-based assay and says, if you have all these antibodies, how many donor organs would you be incompatible with? So a CPRA of 80% would mean that patients would have and be ineligible for, or HLA incompatible with, 80% of the deceased donor kidneys that become available on the basis of having donor-specific antibodies. So here's how we sort of assess whether it's donor-specific antibody. So of course we have the bead-based assay results where we've detected all the antibodies in your patient. And then when the donor comes up, we will have the donor typing. And so it's just a comparison between the two assays to line them up to say, well, are these antibodies donor-specific or not? So to just end, I think I've presented to you sort of like all the varying tests that we have. But it's important to recognize that, like, when thinking about an immunological assessment, it's not just black and white. There's a full spectrum of risk of rejection, ranging from those HLA identical twins where there's no risk of an alloimmune response, to cases of a positive CDC crossmatch where there's a risk of hyperacute rejection. And depending on your patient characteristics and what sort of immunological risk you want to take, anywhere sort of in this mid-range is up to the clinicians to decide whether it's appropriate to move forward with transplant or not. So this table I just put into place so that you can have as a reference. But I basically just wanted to end there and allow Dr. Galeria enough time to go through some cases so she can sort of highlight common things that come up with respect to this. Dr. Galeria?
Yeah, thank you so much to the organizers for the opportunity, and Dr. Young for giving such a excellent overview of the concept of AHLA assays and concepts. So I will be, this is just my credentials. I'm at the BIDMC and I have no financial disclosures. The objectives of this talk would be, we'll just go over the concepts which Dr. Young just shared, and cases to highlight differences between solid phase and cell-based assays. We will also try to get to a case which determines the strength of HLA antibodies. We'll also cover the concept of autoantibodies and learn about possible interfering factors that can affect our HLA lab assays. So just to reiterate, the cell or donor-based assays is where the donor cells are incubated with the patient serum. So it's basically an antigen on the donor to react with the serum antibody in the patient serum. And as Dr. Young just mentioned, T cells are used in lieu of an organ being tested. T cells are used for class 1 antibody testing, and B cells are used mainly for class 2 antibody testing. However, there's a caveat that, all nucleated cells express class 1, so B cells will pick up class 2 as well as class 1 antibodies. So basically, T cell is equivalent to class 1, B cell equivalent to class 2. So the cells, in addition to expressing HLA, they also express on their surface non-HLA antigens, and they also have certain receptors that could also be involved in some of the downstream result we see. And as Dr. Young mentioned, the solid phase bead assay is HLA based. So the next slide, let's take a case, the first case, the patient who has a positive cross-match, B-cell flow cross-match with negative result for any donor-specific antibody. So basically, in the absence of any single antigen bead reactivity in an assay that detects antibodies to HLA class 1 or class 2, what could be the possible reasons for this positivity? And more importantly, is this reactivity relevant to clinical outcomes post-transplant? So the patient, this is just the CDC cross-match was negative, CDC B-cell cross-match was negative, T-flow was negative, only B-flow cross-match was positive. No donor-specific antibodies. So the cell-based assay, as we just discussed, will pick up non-HLA antibodies. We know there's no HLA antibodies in addition to HLA antibodies. So other possible reasons for positive B-cell flow cross-match would be that the B cells on their surface have something called Fc receptors, and also they have surface immunoglobulins. So both of these, to these, the antibodies can non-specifically bind, thereby resulting in a positivity. And this kind of background reactivity is not a contraindication to transplant. In fact, B-cell cross matches, both CDC and flow cross matches, are kind of notorious for giving us a false positive background reactivity, and the literature suggests about 56% of the times this could be non-specific. However, having said that, it is still a very good assay to use for detecting class 2 antibodies. So we have to take it into consideration in lieu of the background reactivity. The post-transplant monitoring, we screen for the antibodies post-transplant to diagnose antibody-mediated rejection, to determine management of AMR by guiding immunosuppression, and also in patients that are higher immunological risk for more closely monitoring for antibody detection. It's persistent or high-strength antibodies may predict poor graft outcomes. So the objective post-transplant monitoring is that which assay should be used and how often should that be followed following treatment. And for the post-transplant monitoring, we need to have a way to quantitate the antibody response. So this is a second case for post-transplant monitoring. Patient has these HLA antigens, donor antigens are these. At the time of transplant and before transplant, the patient has no class 1 or class 2 antibodies. The antibodies, as Dr. Young showed, you have to match it with the donor. So 66, 68, 69, there are no donor antigens, so there are no class 1, similarly no class 2 antibodies. CDC cross-match was negative, and B cell was also negative. So the patient received a transplant, and post-transplant, the patient developed antibodies to HLA-A2. This is referred to as de novo development of antibody to one of the mismatched HLA antigens, right? This was a mismatch, A3, A30. This patient was a homozygous for A2. So there is de novo development of A2 pre-transplant, no class 1 antibody. So this is an important concept which is used for all of our transplants, that you would be going ahead with a transplant which is mismatched, and there is no donor-specific antibody at the time of transplant. However, and then you give them different kinds of immunosuppression. And with the immunosuppression, the idea is that you can minimize the risk of development of de novo antibodies. However, you cannot erase this risk, and that's exactly what happened. That we went ahead with the transplant. There were no pre-transplant antibody. That is the way to go. It was cross matches were negative, but the patient developed de novo A2 antibodies, and patient also developed de novo DQ4 antibodies. De novo antibodies carry worse prognosis if persistent, hence close monitoring is recommended, and that's what was done. So as I mentioned, that for monitoring, you need to have some way of quantitation. And one of the ways which HLA labs use for quantitation is performing titers. Titers are performed to measure strength of the antibody. It's a good tool we have. Two antibodies could start with the same mean fluorescence intensity, right? So at face value, you may think they're both very similar. However, one antibody, the blue one, for example, dilutes out, and the red one doesn't dilute out. They were suggesting that this is a stronger antibody. In the context of a therapeutic intervention, we would think that this antibody is easier to clear with plasmapheresis or rituximab or whatever post-transplant therapeutic scenario you would have. So here, so the titers, I just would like to show that, but antibodies had to be monitored after each intervention. You would think that if they've gone down, you can stop it. Again, having said that, the antibodies are very good to rebound. So serial monitoring is really required. Let's take a case number 3, and we'll come back to the titers later as well. This is a patient which is highly sensitized. Dr. Young mentioned there are some referred to as public epitopes. This patient is making antibodies to BW6. All these BW6, these B antigens have a common epitope, which is BW6. And in addition, the patient has all these other antibodies, making the CPRA to be 97%, which is a highly sensitized patient. Now, we had an opportunity to perform cross matches. I'll come to that. But this profile of this patient's antibodies, right, these antibodies are really strong. So this patient is making these antibodies, and this is how the Luminex single antigen bead assay appears. 22,000, all red means kind of bad. If you see, this is showing you BW6, antibodies to BW6. The antibodies also, we utilize the titer, and they did not dilute out. They diluted out to very little. And then the same patient, when had 47 cross matches, T cell cytotoxic cross matches performed, and 41 of those were actually T cell CDC positive, thereby giving a 87% cross match positivity. So for this particular case, EC, there's a correlation of the screening and the cross matches were very good. You could kind of say based on the percentages. Let's take another case. This patient had a CPR of 62%. These are the antibodies. 62% is high enough PRA. However, only 1 out of 31 T cell cytotoxic cross matches against these disease donors are positive. Now, the question would be that, what would you want to know? We wanted to know the profile. This profile of this patient is really, really low MFI, and the antibodies diluted out, thereby suggesting that it is the antibody strength or profile, because for antibody to create a cytotoxic T cell cross-match positivity, you need to have high molar amount of antibody to recruit the C1q component, and this previous patient was not able to recruit the C1q component because antibody molar amount was low, and hence the cross matches were negative, right? So that's the reason. Now we have another case, which is a autoantibody case. The patient had no donor-specific antibody. The CDC T and B allo cross matches were both positive. Flow cross matches were negative. Now, we want to take a pause to know what could be the characteristic of this antibody. Dr. Young just mentioned that the CDC cross-match will pick up something called IgM antibodies. And from our experience, we know that the autoantibodies in general are IgM kind. And this patient also had clinical history of lupus. And autoantibodies lupus patients would make, and those are IgM. So then, however, we do want to do a full immunological assessment. So we have a tool referred to as the DTT agent, and DTT reduces the disulfide bonds in IgM antibodies. So in this previous allo cross-match assay, the DTT made the cross-match negative, T as well as B, suggesting that reactivity was due to IgM antibodies. We also performed something called autologous cross-match, because that will tell you there are autoantibodies, right? Because we think they are autoantibodies of IgM kind. So autologous cross-match is recipient cells, not the donor cells, with recipient serum. And that was also positive. A positive also autocross match, and again loss of reactivity due to DTT treatment. However, for the CDC cross match, I would like you to refer to an important consideration which Dr. Young also mentioned, is that the rare IgM allo antibodies, if there's a recent sensitizing event, those will be IgM antibodies and they won't have switched to IgG kind. Having said that, I am yet to see a case with the rare IgM antibody, but that is a caveat. Now we're going to the last case, which is a case where unexpected positive cross-match due to interfering substance, which could be your immunosuppressive agent. For example, if your patient is on rituximab, you could do autologous flow cross-match. Rituximab mechanism of action is multitude. However, one of them is the recipient B cells will be depletion. So autologous cross-match, T cell cross-match was performed, B cell we could not perform. That is telling you that patient serum has rituximab. It's an indirect way. When we perform B cell flow cross match, we know the rituximab is CD20, right? And the B cells, if you recall, B cells have CD20 on their surface. So if the patient serum has circulating anti-CD20, it will bind to B cells irrespective of there is any DSA or not, and the secondary antibody will come and give you a really strong positive signal. And in fact, it's so positive that you could sometimes tell that patient is not a real DSA based flow signal, and we could say that this is based on the CD20. So a positive B cell flow cross match after rituximab therapy may reflect drug interference rather than donor-specific HLA antibodies. And autologous cross-match results can help identify treatment-related effects. As I mentioned, if the B cells are depleted, sometimes you need to know whether rituximab is in your system without doing any ELISA kind of your B cells can tell you that they're depleted, and your highly invalid assay can tell you. So now we're moving to the questions. A patient, these are the patient's donor antigens. Patient has no class 1 antibodies. The patient has class 2 antibodies. DQ4, can you click the answer? Or is the class 2 DSA can result in positive T cell, class 2 DSA can result in positive B cell. Cross matches due to class 2 DSAs will always be negative. Class 2 DSA can result in both T and B cell positive cross matches. And the answer is actually that I'm not sure if this poll is going on. Dr. Azi, is the poll going on? Yeah, perfect. Thank you. And if we have the result actually should be, I'm not able to see, but it should be class 2 DSA can result in a positive B cell cross match. Yes, I think it's going to be, which is great. We can move to the next question then, which is a living donor transplant candidate has the following assay results: positive T, CDC, and negative flow. No DSA. What would you do next? Perform DTT, perform autocross match, inquire about the autoimmune disease history, if any, or all of the above, or none of the above. Yeah. So actually, this will be the number. If the second one perform all of these. If you recall that we did DTT treatment on the allo cross match, we performed auto cross matching. We also came to know that there is lupus the patient had, because that kind of confirms that their autoantibodies are IgM kind, and that's why your CDC cross match was positive. So individually, all answers are correct, but all of the above is the best answer. Just to summarize, CDC crossmatch picks up both IgM and IgG. Cell-based assay pick up non-HLA antibodies. Strength of antibody can be tested by performing titers. And the lack of correlation with antibody cross-match could be a function of the strength of the antibody. We saw 2 cases, one was positive, one was negative. And thank you so much.